Everybody, welcome to the meeting. Welcome, Sarah, and the wider team. This meeting, as you will know by now, is one in a series of public accountability meetings with all health organisations. We have a senior team from the Welsh Government here, and you have a selection of the people from the board. There's quite a lot of people in the room, but my suggestion is that each person introduces themselves the first time they contribute, so that we can get into the discussion more quickly. As you will know, the meeting is being live streamed, so members of the public will be able to watch the discussion. Mae croeso I bawb gyfrannu yn Gymraeg neu Saesneg, mae cyfieithu ar y pryd. You've provided a detailed evidence pack in advance of the meeting, for which thank you. And as is always the way in these sorts of discussions, that pack will have provided high levels of assurance for some of the questions that we are going to explore. So the focus of the meeting will be in areas where we're seeking further assurance. So sometimes that will end up looking at things which need more work, and there'll be less of an opportunity to focus on things which are going really well. But you will have that opportunity at the beginning of each section to set out the board's view on that area. So there's an opportunity there for you to highlight whatever you would like to draw attention to. Some of the issues which we'll touch on today have been raised in correspondence from members of the public to make sure that their concerns are reflected in the discussions which we're having with each of the health organisations. And as I said, it would be helpful if somebody from the Trust could give a short summary at the beginning of each section. I would encourage people to try and limit that to around 4 minutes so that we have plenty of time to get into what is already quite a full agenda. And then we can ask questions as appropriate on the back of that. But before we get into the agenda specifically, Sarah, is there anything you'd like to say by way of opening remarks?
Yes, diolch ysgrifennydd y cabinet, and thank you everybody. Dwi'n mynd i siarad yn Saesneg, ond dwi'n hapus iawn at y cwestiwn yn Gymraeg os oes angen. I'm Sarah Mosley, and I've been chair of Velindre University NHS Trust for 3.5 months now, so that's long enough to learn a huge amount, but to still be really quite new. So diolch for the opportunity to come and account for ourselves, and especially to our patients, the public, staff, and our partners, as well as to you and your senior team, Cabinet Secretary. Velindre is a specialist trust, one of the handful of cancer centres and national blood and transplant services across the UK. We benchmark internationally and have expertise and a focus which results overwhelmingly in really good patient and donor experiences. We play an important role across NHS Wales, researching and trialling new treatments, training the expert workforce of the future, and contributing to a system-wide approach to improving cancer outcomes while maximising the potential of the blood service, which is essential for national resilience. Partnership is an increasing focus for us, as demonstrated by the Cardiff Health Partners Initiative, the opening of the radiotherapy unit at Neville Hall, which you opened, Cabinet Secretary, and the Welsh response to the infected blood inquiry. I've been warmly welcomed and supported since I've arrived, so thank you to everybody who's sitting here alongside me, and a number of you on the other side of the table too. So I focused on getting to know the organisation and spending time in the service in examining our performance, challenges and ambitions, reflecting on the organisation's culture and governance and the impact of change on those things, getting to grips quickly with some difficult issues relating to the Trust leadership and to the governance of the Shared Services Partnership, and reviewing progress on our plans and investments, particularly the development of our new cancer hospital and the modernisation of blood services. Cancer diagnosis is rising every year, and so are the range and complexity of the treatments that we can offer. So we're upskilling staff to provide complex therapies such as biospecifics and advanced therapies that just weren't available, and there's a lot to do in that area. Forecasting the developments and getting ready for them is a real focus for us. Our commissioning health boards are under a huge amount of financial and operational pressures. So we won't overspend this year, but we're also putting measures in place to be more productive and more prudent with the money that we have. And for the first time in years, we've got a full complement of independent members and a foundation for building what is a fundamentally sound culture. So the priorities for the board are adapting our governance and leadership to support ambitions and change, delivering on significant investment in our infrastructure and on service change, continuing to provide services prudently and efficiently, and looking outward so that we can learn, adapt and work in partnership with patients, donors and the wider NHS. So I'm sure a number of the themes will come up in questions. So unless there are any questions on that, what I'd like to do is hand over to Vicky, who chairs our Quality, Safety and Performance Committee, to introduce our approach to cancer.
I'll just set the agenda for the public to see what we're covering in the agenda. So firstly, we'll be looking at cancer services. Secondly, we will look at the blood service. Thirdly, we will look at developing services for the future. And then lastly, of the 4 items, we'll be looking at how we are strengthening the NHS more generally and strengthening the organisation in this particular case. Yes.
Forgive me, I didn't mean to preempt.
No, it's absolutely fine. Over to you.
Okay. Cabinet Secretary, my name is Vicky Morris. I'm a Trust Board independent member and I chair the Trust Quality, Safety and Performance Committee, QSP. Velindre Cancer Service is 70 years old this year. Since its inception, the service has consistently demonstrated several defining characteristics, including a commitment to deliver safe, high-quality care with the best possible experience and outcomes, a highly committed and professional workforce, and a commitment to improving services. In my role as chair of the QSP committee, I'm responsible for seeking assurances that the quality of services provided to patients meets the required standard and that we continually learn and improve. Over the last few years, this has been the case, with Velindre Cancer Service delivering services that are safe and good quality. It is also important to highlight that there have been occasions where we haven't always achieved the required standards. For example, the Systemic Anti-Cancer Therapy Services, SACT, didn't achieve all of the required key performance targets for several months in 24-25, where demand increased exponentially, more than forecast, and we struggled to deliver the required capacity. Overall, the current position for 25-26 for SACT and radiotherapy is good in the face of increasing demand. Specifically on SACT, we are achieving a performance of 94% against the emergency SACT target and 97% of the non-emergency SACT. The performance of the radiotherapy service is also good, with emergency radiotherapy at 99%, elective radiotherapy at 98%. The committee has sought further assurances on the performance of scheduled radiotherapy at 87% and urgent symptom control RT at 79%, both falling below our standards of 100%. The quality, safety and experience outcomes have also been positive. We have seen low mortality rates for SACT, 30-day mortality, when compared with the national benchmarks, low rates of infections, for example, C. difficile, MRSA and MSSA bacteremia, and low numbers of nationally reportable incidents. Alongside this, we've seen an overall patient satisfaction rate of 95.4%. However, we are not complacent, as we know that there are several areas we need to work on to further improve the experience of our patients. The Trust is focusing on these improvements, all of which actions are contained within our IMTP and service plans to be fully delivered by December 28. Some examples are developing flexible capacity and delivery of care locally, embedding the delivery of the integrated radiotherapy solution to ensure we're increasing system capacity, implementing standard pathways across the region to support the delivery of the single cancer pathway, the attraction and retention of key staff groups such as physicists, the integration and use of digital systems and technology within the Trust and across the region and nationally, and the provision of more regional solutions to fragile services such as sarcoma. We've established a new divisional structure to enable enhanced focus on quality and performance, and we are learning and sharing by working with other organisations across Wales and wider, such as the Clatterbridge and the Royal Marsden. Finally, we recognise that changing the clinical model can be challenging, especially for the services staff, and we want to thank them all for their support in getting us this far. However, there is more to do. And in support of this, we've placed renewed emphasis on board leadership, culture development, and effective and agile governance. So thank you.
Thank you very much. Sarah, some of the points that you made in your opening remarks, and which Vicky echoed in the opening statement for this section, have been around increased demand, but also more timely diagnosis, improved treatments, and so on. I'm keen to understand what the Trust is doing to ensure that it has the clinical capacity that it's going to need to meet that forecast demand for radiotherapy and for systemic anti-cancer therapy SAC. What's in train to make sure that capacity is there?
Well, our clinical strategy, which was agreed this year, very much looks to that. And I'm going to turn to Jazz to talk about the specifics of that and how it's being developed and monitored.
Thank you. Good afternoon to everyone. Good afternoon, Cabinet Secretary. I'm Jazz Abraham. I'm the Executive Medical Director of the Trust. And I would start off by saying that it is an incredibly exciting time to be part of our organisation and to be part of the oncology workforce. But it is also a challenging time. And the question that you've posed to us around capacity and the clinical model and how do we square that is something that's very much in the centre of our thinking, our planning, and our strategy for the organisation. We are, in a sense, influenced by the evolving oncology ecosystem, which is full of good news. A genomics revolution, an advent of novel therapies, as well as an increased demand in terms of numbers of cancers. So complexity of care, increased patients that we need to see in our system. And how we are preparing for this is in a number of ways. I think firstly, in having a very robust system of horizon scanning so that we can anticipate what's coming over the horizon, link in with national structures such as Advanced Therapies Wales, benchmark with centres of excellence in terms of how they are managing these new novel therapies and getting them into our pathways. We have to focus on our workforce. So actually, what is the way that we will transform our workforce to manage this increased demand? And that is about moving from different models of care. Currently, we have a medically led and medically delivered model. And we recognize the need to move to a medically led and multi-professionally led model, a delivered model.
And have you got the workforce to deliver that model?
So, well, we have some really good successes that we can share with you. So one of them is moving towards virtual assessments. And we have something called the VAP initiative, which has removed about 30% of outpatient contacts to a kind of virtual setting with excellent patient feedback and a projected increase for the next 12 months. That's just one example.
Okay, great.
There are other technologies and innovations that we're bringing in. There's a virtual assessed, let me look at my notes. Ambient voice technology, that's the one. So use of innovation in our outpatient settings to help us be more efficient, to reduce.
Is that an AI tool, effectively?
That is an artificial intelligence tool. We're part of a national program with the life sciences in delivering that. We've also got to look at how we bring patients into our system by using, home care as much as we can. So reducing the footfall of patients within the building to accommodate for that increased capacity.
I just not so I've understood. So if I'm a member of the public thinking, look, the demand is going up, isn't it, for radiotherapies, for all kinds of therapies into the future. We know that, the public will know that. Are you essentially saying to them, look, we are confident that we are able to meet that level of demand because we are adapting our services in a way which means that our workforce are able to work more effectively? I mean, what level
I
of
think-
confidence are you telling the public on that? I think it's a
I
question.
think we do have a strong level of confidence. We haven't got, we've got the skills, we've got the people, and the people who want to be able to deliver this care. So that's the first thing, and they are committed to it, and recognize that it is part of their role. So we have the people. We have to increase the skills, and we are doing that in a systematic way. So some of this is our response to the treatments out there. There's a sense of assessing where we need to strengthen our clinical model in order to deliver things, where we need to skill up our workforce. I think that there are, at the same time, we need to address the transformation. So reducing time in an outpatient setting by actually using virtual assessments to free up that capacity, and do pre-assessments, for example, outside of the clinic, the regular clinic setting. I think that we haven't talked about radiotherapy, but the question, I'm guessing, applies to that as well. And I think through the integrated radiotherapy system, we are already transforming the pathways of care. And that is by having a ARIA, again, another AI-enabled system, which links in, booking as well as outlining patients, so you can track them and see where they are in the system and minimize waits.
So that's an efficiency tool.
That's an efficiency tool, but it also increases precision of outlining. And we have some really good exemplars, one of which has won an award at the Medi Wales conference on digital innovation. And it is about efficiency fundamentally, but also improving the quality of care. So the other element that we haven't talked about, but I think is absolutely key, is using research, embedding research into our systems in order to perhaps free up the capacity within the service. And we do have an incredible track record for delivering research, which helps us to transform our clinical model in the setting of a well set out pathway of care, but also upskill ourselves with new technologies, and increase confidence in managing toxicities, for example, in the setting of a research study. And
could just, because I'm obviously coming an expert in any of this, obviously, but I just wanted to understand in a way how the research link that you're talking about ends up freeing up the capacity. How does that? What's the link between the two?
So, I mean, patients that we treat in a research setting would, if they weren't participating in a clinical trial, would require treatment as part of the service. So for almost every case that we have, it is an alternative to a standard of care. And in that setting, there is a freeing up of capacity that occurs. But actually, more importantly than that, I think, is the quality of care that we can enable through using research, and embedding it systematically through our service.
Great, thank you. That's been really helpful. I know that the Chief Medical Officer and Chief Nursing Officer had questions. So, Isabel.
Thank you very much. I'm Isabel Oliver. I'm the Chief Medical Officer for Wales and Medical Director of the NHS in Wales. Just you've talked about the great benefits that we have from scientific advancements and new technologies, and the need to upskill staff. But I was wondering if you could also tell us a little bit how the Trust is working with health boards and with the Joint Commissioning Committee to make sure that those new technologies and new treatments approved by NICE are being implemented in a timely manner. And also thinking about how you're working with health boards more broadly. Velindre is a specialist NHS trust, as you've highlighted. Our cancer outcomes in Wales must be improved. What is Velindre doing to work with health boards across Wales to drive forward improvements in cancer outcomes for the people of Wales? Thanks.
Thank you. So I'll just break that down into different components. I think firstly, in terms of partnerships, then we have significant collaboration with our health board partners and with the JCC. There are a number of mechanisms that we do that. If we take the Advanced Therapies Wales programme, which we in fact as an organisation host, so Velindre NHS Trust hosts that. I sit on the programme board alongside my colleagues. That has a number of different, well, there's a delivery plan that's just been published and an annual report, but as part of that programme, there are a number of work streams, one of which is where we are looking at adoption of new treatments, and we sit around a table with health board medical directors, JCC medical director, and the leads for advanced therapies experts in Wales to work out how we will create these pathways from research to adoption. So that's one example. Aside from that, we have a very important collaboration with Cardiff and Vale in terms of an exec-to-exec partnership board. And as part of that work, we have set a number of priorities, one of which is along the lines of delivery of complex therapies. There is a very fairly recent initiative called Cardiff Health Partners, which you may have heard of, which is a collaboration between Cardiff University, Cardiff and Vale, and Velindre, which is akin to an academic health science program. And there are 3 missions as part of that work, or 3 particular areas, I should say, of priority areas, one of which is cancer, precision medicine, and sort of neuro work. But actually what that work is trying to do ultimately as a kind of key mission is to improve the outcomes of the population in Wales. And, you know, there are a number of ways that will intend to do that work, and we've set off on a journey to do that. But what's underpinning it, and I think it's an important one to just share with you, is the work of the Cardiff Cancer Research Partnership, which is something that Velindre led 5 years ago. We set off on a journey that was largely in response to the then Nuffield's advice in building the new hospital and the challenge about how we will deliver new advanced therapies, particularly in the context of research. And that partnership has got a portfolio of a number of studies which are helping us again to prepare the way for NHS pathways of care.
Are you seeing the benefits of those mechanisms that you've described yet in terms of better services or better outcomes, or not yet?
Well, I guess in terms of how we measure outcomes, I suppose we haven't got survival data to tell us that is improving, but we have got access to medicines. The story of working with our hem-onc colleagues in particular. I can give you one example of a study called Monumental, where we are the top recruiter in the UK. And that the importance about that study is to share with you that it is delivered by Velindre employed nurses working in partnership with the hemato-oncologists in Cardiff and Vale. And part of that process, I suppose, one of the really important benefits is that that group of nurses have upskilled themselves, have LinkedIn benchmarked and visited a number of centres of excellence, and continue to then train back to the cancer service to train the wider nurse force in being able to deal with these newer therapies. That particular study was about bispecifics used in myeloma, but are now being used in the cancer service. And we have a very good example of introducing one of these bispecifics successfully in the cancer service, which required strengthening of our clinical model. We did it as a pilot proof of concept, and we successfully delivered for uveal melanoma one of these agents with good effect. So that's, I guess, an example of where the Cardiff Cancer Research Partnership has increased our confidence, our skills, created a pathway with a successful outcome for the NHS patient.
Thank you, Jacqueline.
So good afternoon, I'm Jacqueline Totterdale. I'm the Director General for Health, Social Care and Early Years and the Chief Executive NHS Wales. So that all sounds brilliant, I suppose the bit is a bit more for me around, that sounds great for the people who are living around the Cardiff conurbation, but we also, we also look after the North Wales conurbation. So for those patients who live in and around the North Wales, how do we start to spread this so that it's not just our citizens who live in and around bigger cities and towns? It's actually, because we've got quite a lot of landmass, we've got people who live in the countryside. How do actually we make sure that that spread is happening quickly across Wales? Because actually it's that conurbation, that population in those conurbations that probably actually don't get as much access to this sort of level of care than not. So how do we make sure we're doing it sustainably and equitably?
Yeah.
And probably a short answer.
Right. I think we have, we can answer this question. The concept of the Cardiff Cancer Research Partnership is it's got Cardiff in the title because it is being delivered in Cardiff, but actually the access is for all Wales. We have in Velindre, and Cabinet Secretary, I think when you came to visit us to our trial unit, there was a patient from North Wales receiving, BioNTech related viral therapy. Because our doors are, I think the message is our doors are open to all of Wales. We already do deliver services for all Wales in terms of paediatric and some brachytherapy. So, but I agree, it doesn't mean that every patient in those areas is getting access. So I think that we do have a responsibility to provide that leadership in an R&D setting across Wales. We have got the largest number of cancer trials open in Velindre in Wales, and we do have an ambition to link and provide that coverage in a systematic way, but I guess we haven't got that necessarily.
I think that's right. I think there's a lot of untapped potential there, and I think Carl, you can talk about the systemic.
Taking Jacqueline's point very quickly, just 3 quick points back to the Cabinet Secretary. Sorry, Cabinet Secretary, I'm Carl James, I'm the Acting Chief Executive. I know everybody else around the table have mentioned it a few times. Thanks for having us this afternoon. So 3 quick points. In terms of your opening question, it's good timing actually, because we're just coming to the end of our cancer strategy. That ends in December 26. So what have we done so far working across the region? First of all, we've improved access to care, deliver more care at home, more locally, and reduced waiting times. We've increased, as Jazz says, we've recruited the largest recruited, giving access to people to take clinical trials. We've delivered world-leading global impacts to the FACTION trial. We've also provided leading-edge radiotherapy across South East Wales. So that's what we've done so far. To remain, we're expanding our Velindre apps to get across the whole of South East Wales, leading the acute oncology implementation across South East Wales to get to a comprehensive standard. And then we will progress the Cardiff Health Partners. So that's what we'll do by the end of December. The second question, our real focus then, helping the system, the single cancer pathway. We're absolutely committed to doing all we possibly can to improve single cancer pathway. So right now, we've already introduced the PTL in our South East Wales area with next support. So colleagues across South East Wales can see where their patients are. That allows us to pull patients through. We'll also roll that out further. The second piece we are then doing on the single cancer pathway, if I could just find my 1 second, is a shadow reporting, sort of exactly where we are going to move to reduce component weight. So we've got some stretch targets to get down from our current 38 days to be treated by ourselves to 24. So that gives the health boards far more time along that pathway to make sure that when the patient gets to us, we will then treat them on time. So at the minute, the early data we've got suggests there's quite a sort of a variation across that pathway. But we want to try and reduce the amount of time that the tertiary provider takes. So you're
currently 38, and you're aiming for 24, is that right?
We've got a stretch target to get down to.
How long will it take you to get to 24?
We're aiming to do that, Cabinet Secretary, by June 27. So we will then get our component weights down, which allows the health boards far more time to make sure the front end of the pathway goes well, make sure that we need to deliver on that. And that does, back to the question you asked, does then help to improve access, reduce patient weights. The last point, perhaps we pick up later, As a specialist cancer service, we do have a lot of ideas about how we might then, pick up Jacqueline's point, really take a system leadership role across the whole of Wales, with the mandate on behalf of and with our partners in South Wales and North Wales. Some very practical examples we've been discussing. We know North Wales has some challenges with oncology. So how can we help them remotely by giving them some of our oncology consultant time? There's some very practical things we can do right now.
What's the answer to that question? How can you do that?
Yes, we can, and we've started. I mean, we need to put in a sustainable way to do that. Jazz and colleagues have already had those conversations, but what it can't be is piecemeal and ad hoc. It needs to be structured, managed, and well supported so it's sustainable. That's something we can definitely do. We're also having conversations with Abby and Jan down in Swansea, because ultimately some of these, as we know, some of the challenges are regional and macro. So it's a South East Wales solution to some of these service fragilities rather than South Wales rather than a South East Wales. So we need to look for far more along the M4 corridor about A, how do we support working together better anyway, B, the fragile services, and C, the share, the opportunity the NVCC brings. What we've been able to demonstrate is our recruitment and retention has always been pretty good. It's now exceptional. So people want to come and work in Wales. Well, how can we make them not just want to come and work in South East Wales, but Wales as a cancer system? What's our offer as a cancer system which attracts and retains the very best talent? So we might want to speak about that in services for the future.
I think as a second, we can. You've asked some important questions. I'd like to explore some of the answers. Thank you.
Thank you. Thank you. Sue Tranker, Chief Nursing Officer. So my question is, we've heard a little bit from Vicky around your performance and that you've improved that and recovered it in 25-26. So I'm just interested in the recent service transformation that you've had around your SAT and the improvement plan that's gone in, where you've introduced nurse-led immunotherapy clinics, and what impact have you seen on patient outcomes, waiting times, and what have you learned from that to then apply to the rest of your workforce transformation?
Yes, thank you very much.
Thank you. So one of the transformations,
Apologies.
I'm Nick Williams, Executive Director of Nursing, Allied Health Professionals and Health Science. So excited to answer the question. Yes, so as has been discussed already, so one of the movements we are seeing is to many multi-professionally led models and nurse-led therapy clinics and pre-SAT assessment clinics are one of those developments. And really just about making sure that we put our workforce around the patient to develop the best possible care. What we've learned as we've been doing these is, first of all, to think about the patient journey, map what the patient journey and pathways, what are the points, where are the duplications, and what are the opportunities for care and services to live differently. And the best people to do that are our staff. So it's not about the top-down approach, it's actually working with our staff itself. Come up with solutions. Our role as leaders and the team in the cancer service is to actually support the staff to develop that transformation themselves. And what we've got within the immunotherapy service is a really fantastic multi-professional service that is not only helping our patients, but is actually providing a national service again. So, our team take calls from clinicians from North Wales and other parts of Wales where, immunotherapy treatment is causing problems, and actually they can help and advise and support the management of those patients due to these emergent treatments. In respect of your outcome question, that is an area that we are working on. So we are currently through our value-based healthcare programme rolling out a programme of PROMs, which is trained patient reporting outcome measures. So we've started to roll that out. It started in September, and we are hopeful that in the coming months we'll be in a position to start having the data feeding through from that, and then how we can align that to our services so we can properly start mapping the outcomes.
We're just a little too early now.
It's a little bit too early, and it'll be around 3 months' time we anticipate when the data will start coming through. Experience is another area that is really important. So that what is the experience of the services that we are providing
From a patient experience.
from a patient experience perspective, and what we know, as we've been told already this afternoon, is our experience generally is good. There are hot spots in that, and one of the areas that we are told by our patients sometimes, the wait whilst they're in the departments is too long, particularly in outpatients. And what we are seeing is where we are able to provide different models of care, and particularly nurse-led or pharmacy-led models of care, actually they deliver in a slightly different setting, and those waits are somewhat less.
Does that reflect the sort of point that Jess is making at the end?
Yes.
Is this a similar thing?
Yeah. Okay, I would like us to pick up later on the workforce transition. I think your learning is interesting, but it's almost put back on the onus of the staff to draw from their own kind of appetite for this. I want to understand what you're doing strategically, but we'll pick it up later on.
Okay, in the third section, perhaps we can come on to that. Great, sorry, diolch yn fawr am hynny. We'll move on now to the second part of the agenda, which is in relation to the Welsh Blood Services. Sarah, who would you like to lead on that?
Well, Vicky's going to introduce this again
Yeah.
because our QSP has governance oversight blood service too.
Thank you. The Welsh Blood Service WBS plays a fundamental and unique specialist role in Wales. NHS Wales could not function without it. We deliver plasma-derived and recombinant medicines for health boards across Wales, a range of diagnostic patient reference services, including antenatal screening and transfusion services, including the manufacture of blood components, testing and distribution to NHS Wales. What is perhaps lesser known is the delivery of our transplantation services, typing donors and recipients of stem cells and organs, delivering international external quality assessment service for histocompatibility and immunogenetics, the recruitment of volunteers to the Welsh Bone Marrow Donor Registry, and our status as a collection centre, an international importer and exporter of stem cells. On the whole, performance is excellent. We are focused on delivering the Talbot Green infrastructure project and new key digital systems to address current material risks and secure service resilience for the future. During the period in question, WBS's performance remained strong. Stocks of red cells were solid across all major blood groups. Red blood cell waste was limited, demonstrating a great alignment of supply and demand across Wales. We made exceptional progress in recruiting stem cell volunteers to the Welsh Bone Marrow Donor Registry, surpassing our annual target with a particular focus on our ethnic diversity reach, given this is an area of higher unmet demand. Lastly, our antenatal results turnaround has consistently exceeded performance targets. However, challenges remain, and the board and committee continue to seek assurance on the following themes. Red cell stock levels fell below the 3-day supply threshold on 3 occasions in September for O-negative red blood cells. The situation was actively managed through our daily resilience meetings and did not affect the provision of blood to any hospitals during that period. For red cell reference serology, we only met performance requirement for the turnaround times once in the last 2 quarters. However, the team had already recognised the need for improvement and recently completed a comprehensive service improvement initiative completed in Q2, which led to a marked improvement in Q3, well above the target. The service continuously balances the need to focus on existing donor engagement to balance supply and demand, and the need to increase the donor base through appointment availability. We need to improve our engagement with the diverse communities of Wales to ensure that the blood donation panels are representative of them. This is a long-term ambition that will be achieved over time and will only work if we co-produce solutions. WBS is transitioning to a clinically led blood donation clinical model within our communities, with the aim to deliver a more person-centred service, reduce variation and strengthen clinical oversight, ensuring a modernised approach that meets future service demands. Perhaps most importantly, we are learning the lessons outlined by the infected blood inquiry, with patient safety as our guiding principle. An opportunity beckons with the Welsh Government's approval in August 25 of the Plasma for Medicines business case. The service has made good progress since then and remains on target to commence supplies of plasma to the fractionator from September 26 onwards.
Okay, thank you. So you said in your there is an underrepresentation of ethnic minorities which in the donor base which needs to be addressed, which I agree with. That's clear. What I'm interested in hearing, Sarah, from you and colleagues, is what the board is doing to hold the Welsh Blood Service to account for recruiting and retaining a more diverse donor base. So what is actually, you're setting the right objective, or what's actually happening to make it to close that gap?
So it's been discussed at QSP consistently. In fact, we discussed it again on Tuesday. And we have overseen plans by the Welsh Blood Service to address that shortfall in donation. And Alan can tell us what's been happening over the last few months. And I know you're going to come and see for yourself.
Yes.
Next week. We have made really good progress. So Alan, perhaps you can describe how you did it.
Good afternoon, colleagues. Alan Prosser, Director of the Welsh Blood Service. So I think fundamentally the service has put in its strategy front and centre the need to the donor panels need to represent the communities that we serve. You'll see in the evidence pack strong information about the statistics and how we're starting to move that. If I talk about blood donation in particular, there is a real need to recruit into our Black heritage donor population for sickle cell and thalassemia support to meet that need. We have a range of plans that we put in place to support that recruitment. The main one being, and what has really taken off for us, is our educational programme. So we have hugely strengthened our educational programme. We go in, educate schools, colleges, sixth forms, etc. And at the same time, we are doing blood drives into schools. So that is looking at the next generation of donor, and is also having huge results in terms of the population that we serve and introducing those to blood panels.
How long have you been doing that for then?
So we've been doing that over the last 12 to 18 months is where we've geared up that education programme. So that's been a great performance. In tandem with that, we've also been recruiting through a new pathway called a buccal swab to recruit into our stem cell register. And again, we have had huge improvements in targeted donors. We are achieving 15% on average over the last 12 months recruitment from ethnic communities on a population that is on the last census 6.2%. That's not to say that we're stopping there or stopping on our laurels. We are doubling down on those efforts. We have future plans in terms of engagement with our donor communities. We talked earlier about the population. We have 2,500 ambassadors providing to support our service. We have
service generally
across the whole of Wales is the way I look at this. And that is, we will start to have targeted discussions with support of those services. We also reach out and take learning nationally. So there is a Blood and Transplantation Alliance, which is a coordinating voice for charitable groups from these communities. And we've really taken some learning from them in terms of targeting annual days. It's not just about recruitment, it's about education. There are some cultural challenges here. But going forward, we will be starting our Donor Voices programme, looking at these ambassadors, these recruits, and truly trying to co-produce with them about the journey that we're on and the reason why we need to change the dial with the population we serve for blood and stem cell.
So what would you say today is your best estimate of when you will have the donor base into a more, and it's sustaining that representation as well, isn't it? It's not, as it were, hitting a target, it's making sure that continues, obviously.
Exactly.
So just help me with that, what's your sense of when, if the plans deliver as you hope that they will and anticipate that they will, when do you feel the service will be able to say comfortably we have a representative donor base, and now the challenge is maintaining that?
Well, I'm into 2 years of a strategy, which is a 5-year strategy, and I think that there is something about the delivery and sustainability that are really good, encouraging results through education. We need to do more with these community groups. We need to be representative of those communities we're speaking to. But we have a great population of donors supporting our service. Strong support for our service. We are community-based, we are citizen-based, and I think there is a strong culture in Wales to support this service. So it's turning a tanker.
Yeah.
Okay. But I'm encouraged from where we're going, and I would see some steadiness in that within the next 2 to 2.5 years.
So you think it's maybe 2.5 years away from getting to a
Yeah.
place where you would say it's more
But encouraging
effective than
results as we
other
go through, and more work to do in this area, but we are doubling down.
Okay, thank you. I don't see any questions on the effective blood inquiry, perhaps on this as well.
Thank you very much, Cabinet Secretary. So my question, and thank you for updating on your oversight of the effective blood inquiry for and enhancing your the safety mechanisms. I'm wondering what assurance you can provide on the lessons that Velindre has taken from the effective blood inquiry. How are they fully embedded across the Welsh Blood Service? And particularly, I guess I'm interested in digital connectivity, staffing, education, government. So any of those, all of those, I'm really interested in the progress you've made in the lessons.
Okay. Well, in responding to your question, I want to firstly acknowledge the assessment of Sir Brian Langstaff in the inquiry report that the treatment of men, women and children with infected blood and blood products from the 1970s to early 90s was the worst treatment disaster in the history of the NHS. As a trust, we sincerely apologise for the tragic hurt, pain and loss for everyone infected and affected by blood and blood products. Lauren, who's with us, chairs the Wales Infected Blood Support Scheme, in which we currently support 250 people either infected or affected by infected blood, and can provide any further details you may like. I'm pleased to share that we received excellent feedback at the end of December from the Chief Secretary to the Prime Minister on the payment of the latest interim compensation payments and the quality of the ongoing service. In terms of delivery across the recommendations, the Trust recognises the leadership role it has in Wales to deliver on those recommendations, working, of course, in close partnership with Welsh Government and NHS Wales through the Blood Health National Oversight Group in particular. The Trust has considered progress made and the risks to the successful implementation of the recommendations at various points since May 24. In Quality, Safety and Performance Committee and in the Trust Board. Only this week, we are articulating and reviewing the totality of the risks we are managing. Through our work, we've identified particular risks and challenges in digital staffing and training recommendations, but the Trust is contributing across a range of recommendations from that review. Recommendation 1, compensation. Recommendation 3, clinical training. Recommendation 4, achieving a safety culture. Recommendation 7, blood transfusions. And recommendation 10, giving patients a voice. So I think Lauren, obviously from a WIBS point of view, could comment further on that if that would be helpful. So Lauren.
Thank you, Vicky. So the Wales Infected Blood Support Service, as you would have seen in the inquiry report, there is a national service being set up, the Infected Blood Compensation Authority, but there's been some delay to that service being operational. So the 4 nation schemes are continuing to run in the meantime, and we've been asked to process the compensation payments, the interim payments over that period, and to continue with the service that we are providing to the claimants of our scheme. So that includes financial support, but also extensive counselling and psychology packages of care. And then wider services around support with benefits, etc. So the scheme is coordinated by our colleagues in shared service partnership, and then major parts of that support service are provided by the Velindre Cancer Service. And as Vicky mentioned, I chair that scheme with representation from Welsh Government as well.
So you describe the process really well, thank you, for how you picked the recommendations, how you set yourself up. And I guess I'm interested in how you've embedded those lessons, is that's what I'm asking. And I understand some of the national that you're waiting on, and your process sounds sound. What you've not told me yet is what lessons you have learned as a Welsh Blood Service. So where do you enhance the safety?
So if I could pass to Alan, because then we could pick up from an operational point of view the recommendations. We could come back to governance if you wish in terms of QSP's oversight.
Thanks for the question. So fundamentally, it's about transfusion safety and improving transfusion safety. So since the publication of the report, we've actually supported the system with 2 Welsh Health circulars. The first one relates directly to use of tranexamic acid before transfusion, We took advantage of that Welsh Health Circular by reminding colleagues about prudent blood management and good health management of blood services. So, you know, pre-op anemia pathways that we've introduced recently within the service, cell salvage techniques. So there's an embedding of that recommendation through that circular. The second circular that was issued about 5-6 months ago was about strengthening governance arrangements. Our service has been strongly involved in the UK reporting tool for serious hazards transfusion, named as SHOT. And that is about learning and is about near misses, and that is a national reporting tool, and that needs to be embedded alongside hospital transfusion committees in terms of safe practice. So I think that is good progress. Training education that you picked up on. Next month we will be issuing a training and education in Welsh Health Circular. The Welsh Blood Service has led at a UK level the mandatory training of resident doctors. Learning from the inquiry will be embedded into their training platforms. Non-medical prescribers will be mandated through the training from our service and our blood health team on safe practice for blood transfusion. So I think that is a system-wide embedding. We have 2 other things in this area.
Before you move on, I think that's just, I will come back in a second, but I know that all sounds, you know, a very comprehensive range of steps. How will you know if it's working?
Coming on to my second stage. So there are 2 other main challenges which are in the hard challenges, the slower burn, so to speak. So it's about digital connectivity, feeding of the blood to the patient's bedside and actually understanding the outcome of those patients. We need to know who's transfused it, by what specialty, into what patient. There is an opportunity in Wales through the LIMS delivery to add on that to the LIMS. So the blood service has supported a requirement alongside DHCW colleagues to understand what the gaps are, because we have almost a mixed economy currently within health boards about, you know, some people are using digital systems, some people are using paper systems. We want one system that delivers that, and then a central repository to be able to report all of those recommendations to the Blood Health National Oversight Group so it can scrutinise. So it's not just digital gaps to the feeding of the blood and connecting the LIMS system, it's actually those prudent health principles. How do we know that people are using the preoperative anemia pathway that we are getting excellent results from for in women's health in particular, and helping to oversee prudent practice within the health board.
Can you just describe for everyone who might not know what LIMS is?
Sorry, Laboratory Information Management System, which is a national rollout. So we will look to bolt on as a LIMS Plus going forward when we understand those requirements. And I'm looking to put those requirements and those gaps together by Q1 of this year with digital healthcare colleagues and the health boards.
So that LIMS system and what you wish to do will enhance your oversight and be able to monitor and see that. The Cabinet Secretary asked, so all of the work that you've put in place so far around the recommendations, how do you know it's working right now if we're still waiting for the system to tell us some of those outcomes and those outputs? So are you assured as a board that the recommendations that you are leading on the effective blood inquiry and all other health boards who are delivering the blood that comes from your service, that it is safe? And how do you know that? And that's what I'm trying to understand. There must be a mechanism that you have, or are you still in development of that mechanism?
I think we're still in development, but I think strengthening governance, hospital transfusion committees, leaning our leadership to support those to escalate concerns, the national reporting of serious hazards in particular. We're about to establish the mandatory training. We will be able to monitor that because we will be controlling that for Wales. And similarly with tranexamic acid, there will be a reporting tool through the pharmacy system that is being delivered into Wales. All these will feed into the National Blood Oversight Group, represented by all health boards who have nominated key clinical leads into that group to oversee clinical practice within their health boards. But work in progress.
Okay, thank you. So Chair, I'm going to argue it'd be really helpful for the board to think about for the future, and we'll come to that for how you strengthen your services. Just really about consideration of the impact that the recommendations are having in the here and now, so that you should be able to demonstrate your impact rather than the waiting for the future. But I think you have some good stuff to tell.
Yeah.
It's just how you perhaps bring some of that.
Yes, and I think we're very clear as a board that the biggest risks we're carrying here are around the digital infrastructure across Wales. And there are some clear dependencies with other organisations within NHS Wales in terms of those risks. Now, we're working really, really hard to try and address those, but there has to be a partnership approach to some of those digital solutions so that we do have a more comprehensive form of assurance right across the service linked into partner organisations. And, you know, we're really clear sighted on that. And I know Alan, Carl, colleagues are working incredibly hard with PCHW and others to look to see how we can really accelerate the pace of that.
And is that going well?
Yes.
Yeah, so like it's good timing actually, because back to this concept of strategic importance, isn't it? It's a resilience issue in terms of level of safety. So yes, it is. We're working well with DHW. There's two things Alan's mentioned. So we're in phase 5 for limbs. We got the spec for the bolt on. We want to go vein to vein. What happened yesterday, we were able, and colleagues around the table might know, we've been out to procure our new blood establishment computer system, which is a most significant moment. And yes, and we've had some challenges because one of the unsuccessful bidders challenged us. So we were able to sign that contract yesterday. So we had colleagues across from Italy. So that enables us now to really accelerate. And we meet weekly with DHW on a range of matters. This is on the national set of plans. And I've been speaking to Helen Thomas and also the chief execs to make sure that we are collectively cited, and with your support and theirs, make sure it gets up the audit. Because one of the things we do find challenged as a blood service is sometimes, and it's not just us, it's UK and wider, is we seem to sometimes sit on the periphery of the mainstream of digital and technological advances. We need to be part of the overall NHS mainstream system. So that's one of the things we need to try and do, and we are doing successfully. But I think in fairness for DHW colleagues, they have challenges across priority and order as well. So that's the thing we're working through with them. There's a group of chief execs into the DDAT board. I think that's where the real sense of priority and order needs to be coming from. But we will do everything we can, and so are they. So I think it's a good partnership. It just needs some real clarity on priority and order. I know the Deputy Minister came along a couple of months ago, so that's really starting to take shape.
Good. Okay. We're going to move on now to the third section in the agenda. Thank you. And this is around how the trust is developing its services for the future. So Sarah, who would like to clear them up, please?
Yeah. Good afternoon. I'm Lindsay Foyster. I'm the Vice Chair and Chair of the Strategic Development Committee at the Trust. In our discussion so far today, we've touched on a number of elements that are relevant to this section, and it's clear that we're undergoing a major programme of organisational transformation. I just want to say that the voices of patients and donors have been central to shaping our services and ensuring care is person-centred, equitable and effective. Also key to our success is how our staff work together and how we develop those partnerships that help us deliver for our patients, donors and communities. A portfolio management approach is in place to optimise delivery, uphold good practice and standards, and provide assurance with all major change activities being assessed and prioritised. We've heard a little about research and development, but it's really important as research development and innovation underpins our high-quality cancer and blood services. And in Velindre Cancer Service, our research portfolio includes 209 studies in setup, active recruitment and follow-up, and includes key exemplars of success in designing, leading and sponsoring, such as PAPOS, which is the largest head and neck cancer radiotherapy study ever carried out globally, and the FACTION study, which we've heard a little of, and that's led to NICE approval of the drug for metastatic breast cancer. The Welsh Blood Service has undergone a major refresh of our research portfolio, which focuses on transfusion, transplantation, component development and service resilience. The Cold First programme is an emerging flagship project. This supports the Welsh Blood Service ambition to become recognised as a leader in cold stored platelets, a core element of UK resilience in the changing geopolitical environment. Our innovation portfolio includes 22 active projects supporting service improvement and transformation. Key successes include collaboration between the Welsh Blood Service and Project Dragon's Heart on medical delivery drones for urgent supplies, including blood. The National Advanced Radiotherapy Cymru programme brings together the 3 cancer centres across Wales with 13 approved projects, enhancing radiotherapy, technical skills delivery and collaboration. And the progress towards ISO 56001 accreditation will be notable as we become the first organisation in the UK to achieve this earlier this year, demonstrating the strength of our innovation framework. Strategic partnerships are integral to our operation and ambitions. Meaningful transformation isn't possible without them. We've heard a little of this already. We're actively involved in the South East Wales Regional Joint Committee and leading on the South East Regional Cancer Programme. And the recent launch of the Cancer Health Partners Strategic Partnership brings together academic, clinical and industry partners to accelerate innovation and improve health outcomes. Also, as a committed learning organisation, the Trust has established the Velindre Oncology Academy so that the multi-professional oncology workforce in Wales no longer need to travel to England to receive specialist multi-professional non-surgical oncology training. In terms of our key infrastructure development, we are on track to deliver the new Velindre Cancer Centre with the first patient to be treated in April 2027. Key milestones have been achieved and risks are being effectively managed both in terms of construction and our overall readiness work. Plans are also in progress, as we've heard, for a major redevelopment of the infrastructure of the Welsh Blood Service at its main hub in Talbot Green. This investment is crucial for the resilience of the blood in Wales, as an essential component of our health service provision, population health, emergency preparedness, and our national resilience framework. The key to all our success, as we've just touched on, will be the integration of our digital infrastructure and systems with all of our transformation programmes. Alongside the progress that has been made, the board is well sighted with the risks associated with this area, as Sarah's just touched on, and we routinely seek assurance given the interdependent, regional and national nature of these digital programmes. In summary, the Trust has a strong track record and is well positioned to face the challenges ahead in expanding patient access, enhancing service resilience and maintaining its leadership in cancer and blood services for Wales.
Thank you, Lucy. So because that's very helpful in getting the sense, as you know, there's a huge number of projects in a very innovative space. What I really want to get a perspective on, though, is, you know, given the level of demand, given the level of technological opportunity, given the level of investment that's already being made, what would you say as a trust is your vision for how services are going to be delivered in the future? So I get all the individual projects, just genuinely very helpful. But how would you say? What's your vision as a trust for the future of tertiary services, and what does that mean in terms of changing the model? We've heard some of it already, but you know, is this about doing what you're doing more efficiently? And there's room for all of us to do that, obviously, so it's not a particular point for the board, or is it about, you know, genuinely new ways of doing new things, as it were? So just help me understand that a bit better.
Yes, I think the new cancer hospital and the model of working, the Velindre model, and some of the national initiatives that we've heard about give us a real opportunity to create a beacon for Wales in terms of the ambition and the outcomes of cancer care. I think we are working towards a service and a network that everybody's going to be really proud of across Wales. And I think our vision is that that's enabling as much as treating. And I think, you know, what's special about us, I guess, is as a specialist trust with, you know, the depth of knowledge and understanding that I hope you're getting a flavour of here, is that there's potential for us to lock in a great deal more, to work with colleagues on how that expertise transforms cancer care. I mean, the number of, you know, somebody born the same year as me, 1966. You know, half of my contemporaries will get cancer, and we know that is increasing every year. And we also know that we have an exponential growth in the range and complexity of treatments. So we have to be able to take advantage of those things, but also to feed back to the rest of the system that this is where we're seeing inequalities in outcomes. These are the things where there might be opportunity to intervene earlier in the system. So I think our vision is to very much play a central role in terms of shaping those things nationally. And I think, you know, we're at a different phase in our development now, because my sense is that the Trust has been very focused on getting the plans for the building over the line, and recovering in terms of the blood and transplant service from COVID. And colleagues around this table, I think, have done an amazing job getting through that and getting us to a place where we can really fly in terms of those national contributions that we've got to make. And one of the things, if I just say this quickly, one of the things when I came in, we had so many priorities that Lauren is leading a portfolio approach so that, and we're in a process, I think, of really boiling down to what are the handful of things that we really, really want to do. I wouldn't say we're completely there yet, but we're challenging ourselves really quite hard to be a bit more disciplined, even because you can't do everything brilliantly. So we are challenging ourselves to do that. The IMTP is an opportunity, and the portfolio approach is an opportunity, but we're really clear, you know, there's some really big wins for Wales here.
So we're definitely going to come on to the new centre, obviously, in a second. But I just wanted to just to dwell on this for a second. So obviously, and I think there are financial constraints, obviously, and the commissioning model where your commission to provide services has inherently constraints, I guess, from your point of view, isn't it? I understand that. So I guess my question really is, do you see that there's a different role that you could play in the system, which is a sort of system leadership role?
Yes.
So you can reach into and get, I mean, I'm not being pejorative, I don't mean to say more proactive, because you may very well be proactive, but where you're sort of taking a step forward to the system and saying, actually, let's redesign it like this so that we can bring our incredible expertise to bear kind of at all levels of the service.
There's a thirst for that.
Okay.
Absolutely.
So
I think naturally, I think there's three things we need to be doing. The first is delivering on the things we've committed to. So all the things we described today around waiting times, the new cancer centre, so on and so forth, that is an absolute given. The second thing related to that, we've already started to do, is to understand what really great tertiary services look like out there. So we've been spending time working with the Clapham Bridge, the Marsden, Kettering Sloan, not just in the UK, but wider. So we know we're not there yet. Okay, we know we're not there yet, but we've got to get there. So that's in our control. That's the thing we must do for the system. That's the first bit. The second bit is your carrot, I suspect, because we also are interested in, we're working with the Federation of Specialist Hospitals, so we also understand what highly specialist cancer services do in other systems. So, for example, they set standards, shape policy, lead research, global impact, the bigger one, workforce leadership education. How can we start to really influence that as a system leader? Now, I'll be honest as well, you Cabinet Secretary, we've been in that space a little bit before, and in fairness, we didn't probably collectively agree who's leading on what in terms of South East Wales and Wales. So I think we're absolutely committed then to getting into that space where we do think we've got something special to offer, working with health boards with a mandate across South East Wales and Wales. That's the next thing.
So partly you're saying to me, it's about being clear about roles and responsibilities in this space, really.
Yeah, but I think I've had conversations with all the chief execs, and they've been pretty clear with us, you know, that you're the specialist cancer centre. So why wouldn't you want to step forward? And we absolutely do, 100%. But the first thing we've got to do is be brilliant at what we do. And we're not there yet. Okay, we're getting there, but we're not there yet. But we've got to get there, because that then gives us A, the mandate, B, the opportunity to step into that space. The third bit, I think, is the system. And I think, Jacqueline mentioned at the start, let's not forget a couple of years ago, we got the Audit Wales report, which said, despite best efforts, we're not where we want to be in terms of outcomes for Wales. We got the MAG report, we got 3 million in Wales and a planned care system. So we're also really interested, and I've spent some time with Nick and others around what does the system configuration look like in Wales for cancer. We've looked at other systems, we've got alliances in Scotland, England. It doesn't really matter as long as we're very clear on what the outcomes we're seeking are, clear on purpose, clear on who's best placed to do what, and have a coherent plan where we all understand how we deliver. So we're also interested in that part of the discussion. Very clear as well, having met with Chris Clayton and colleagues, that post May, not just the election, but post when P&I get in and everything else, there's a sensible conversation to be had around once the clinical strategy is developed, what's our role going forward? But absolutely, we are 100% committed and want to do far more than we are doing now to help improve outcomes across Wales.
If I can just ask about one bit of that, and maybe it should be you to answer, Jazz. You've talked quite a lot in most of what you said about research, clinical trials. And I would expect as a cancer preventor, you do huge amounts of clinical trials because most of your patients will be on one. And the bit that actually defines the good cancer centre with the great ones are those ones that actually are leading the research rather than actually doing the trial for it. So my question to you is where your ambition is. Where are you now? Where's your ambition to actually be a leading light in cancer research, not in trials, in research across the UK and more? Because that not only unlocks us becoming an innovative cancer system for the UK, it also unlocks revenue for you. That actually means you can invest it in Velindre and the Velindre Plus, if you like, to actually make sure that we are really, really becoming a centre of brilliance across the UK, because that will be the defining bit for you.
Yes, yeah. And we've talked a lot about this because we've been disproportionately, I think, dependent on our brilliant charity to fund research, and we need to reverse the proportion of pharmaceutical company type income that's coming into us, as opposed to it's 30-70 and it needs to be 70-30. And I think, it's absolutely key. So
that's also employing the right oncologists for research.
Absolutely, it's a great question. It absolutely is part of our research strategy. We have a strategy in place, which is a 10-year strategy, and there are 4 themes in that, which is around putting patients and carers in the centre of what we do. It's around the advancement of new therapies that I've already covered. It's about driving translational research through connecting the lab and the clinic. And I think in that space, there is work to do. The Cardiff Cancer Research Partnership has started that work. One very exciting example is of a oncolytic virus, which has been, the technology of which has been developed in the lab at Cardiff University. That's reached the first patient in the UK, a test study that's delivered. So it's Velindre working in partnership with Cardiff University and Cardiff and Vale and that is leading what will be transformative research for the future. That's one example. I think that there is a paradigm shift happening in our strategy around the use of commercial trials. And I know we've had some conversations, Isabel, about how we do this, because we need the capability to understand how we can scale this. We've got the investment from VPAG, voluntary pricing. I can't remember the whole piece, but I think we all know what VPAG is, and that will enable us to invest into things that will unblock the pathway that we currently have, access to biopsies, radiology, finance, input into making our systems more agile so we can do more commercial research. But we have made a decision as a trust that we are going to make that shift. And we are benchmarking with our partners. Clatterbridge, for example, have managed to do this. We've met them. We're going to link up and learn about how we can do this at scale. I think the other piece, the 4th theme that I haven't mentioned, is about how we embed research into our organizational structures. I think the historic clinical trial space has been a medically led, medically owned space. We absolutely recognize that the future of research is this and is actually making it accessible to all. And that's our multi-professional staff, but also any member of our staff. Walk into the new cancer centre. As soon as you walk through the door, there should be a study that enables you to participate in and that actually collects data and outcomes. The question, Isabel, you posed, how is it going to make a difference? And I think that is that is the vision that we see for ourselves, that absolutely it is part and parcel of business as usual. And how we will do that, some of that, which will link into the new structures that we've put in place, is a balanced scorecard approach to performance. So when we talk about performance, not only will we show you our SAC performance radiotherapy, we will tell you how are we recruiting against breast cancer, lung cancer, and what is the impact that's having. We're going to collect data on costs, savings potentially. There are significant cost savings that we could make by, accommodating commercial trials. And the one other piece in terms of investing, how do we bring that specialist workforce? How do we attract that workforce of the future? We absolutely need to do that. We do not have enough medical oncologists with academic functions in our organization. Through the faction study that you've heard about, we've had investment. There is a plan with that investment to absolutely employ, and we've got a whole plan over 5 years, to bring in some of these world leaders, UK leaders, to help us set up a whole pathway of, translational research. We need to do it properly. We need to support them with the labs and the whole piece.
Can I just ask before I bring Isabel in? Can I just in terms of the deepening of those commercial relationships that you're talking about, does the trust have clear targets about what it wants to achieve?
Yes, it does. So there's a whole phased plan, which will be, metrics monitored on a monthly basis. There's a whole strategy to that, and part of that strategy is actually having a very different conversation with my colleagues to say, how will we get you interested in participating in commercial trial? That might be that as a tumor site. So one example from Clatterbridge is actually for the breast team. If you recruit and meet your target, you will actually benefit financially. Okay. You reinvest in the service.
So I think from this component of the discussion, we've been exploring that there is a lot of potential in Velindre to really help us achieve better outcomes for the people of Wales in relation to cancer. And there are potentially sort of 3 key areas. So we touched on the system leadership role. And Carl, you were talking about the fact that you needed to do, what you're doing at the moment, well enough to be able to perhaps step on in greater in that system leadership role. But my challenge would be that the system needs you now, and you do need to do both things at the same time. There's a second opportunity, which perhaps the Cabinet Secretary will come into, which is the opportunity from the new Cancer Centre, and understanding how are you going to use that to really transform and modernize services in Wales, and how are you going to take the workforce with you. But the third one is R&D. So just going to that, congratulations on all that you do, which is great. But the opportunity here is about taking a more strategic approach, being more intentional in your R&D activity in a way that delivers, greater benefits for the people of Wales. So not just responding and taking advantages of opportunities that come to the door, but how do you think more strategically about what are the strengths and the assets that you have, and how you use those to advance cancer R&D in Wales. So not necessarily for a detailed response now, but more of a challenge to thinking about as you develop a new strategy. How do you take that more strategic approach, and what do you need from us and Health and Care Research Wales to support you on that?
Yeah.
Thanks, Isabel. Just to clarify, my first point, I'm not suggesting we're not doing that now. We are, in terms of the system, we're doing an awful lot and playing a large role around this table, exec directors, clinical leaders. I think on my mind, perhaps pragmatically, is like we've got to deliver the new cancer centre on time as well. So that's the thing I was describing. We're not doing anything until that's done. I think that just is a really big mark, and we're sort of. So the second point really around.
Sorry, if I could interrupt you for a second. And I think you're probably doing this, but you can't wait until a new cancer center is ready to think about how that will help.
No, I'm not. I'm just giving you assurance that we're not just waiting. There's a small team dedicated doing that, but in terms of my accountability, I've got to deliver that. But I think we're doing things now, and we've got as I said, we've got a plan which will be for the next 5 years, which picks up your points. The second bit, I just wanted to talk about the strategic opportunities, and we've been discussing that as a board, because we know a couple of things. There's a massive opportunity for us and for Wales in what we're doing now, but also with a new cancer centre. So we've seen examples of that where we've already got a good relationship, but they've now gone to a different level. So Jazz and I met with Pfizer on Monday. We've got currently got Varian as a major strategic partner. We're trying to collect strategic partners with 10 or 15-year relationships, because we think that would be better and better leverage for us and for Wales. And we've got a lot of interest. We're trying to make sure we understand what they want, we understand what we need, and put that together as a strategic proposition. Because we also know, back to the earlier discussion, the funding is difficult. So what we need to do is maximise the opportunities, A, to get better outcomes and better systems in Wales through those partnerships and different capabilities, and B, allow, because my test is, as long as that money goes back to my mum in NHS Wales, that's a decent test to apply. So we can do that, and we're on the road to developing the final commercial plan by the end of sort of 12 months away, Jazz, and we're going to land a couple of things, but we will then have a very clear articulation we've described in terms of our commercial trials, 2070 rebalanced, 2080. Clearly where we are with, we've got some private services, what we're going to do with those, what our main partners are going to bring to the table, and what benefits they expect to receive and what we expect to receive over the next 5 to 10 years. So I think we are getting there, Isabel, as we described when you came across the new hospital. There's a tiny bit to go.
Okay, so I want to discuss the new centre. So Nick has some questions.
Thanks, Cabinet Secretary. Nick Wood, Deputy Chief Executive of NHS Wales. So, Carl, you described the building process. I think we're about 14 months away from handover as it stands. 16 months to first patient fees. So building the building is the first thing, and clearly that's a big mark. Confidence in the plans around operational readiness, your ability to deploy your workforce, the way in which the centre will work in a new system, in effect, is what you've described. So I need to understand where you are from that perspective. I also keen to understand how you're then going to manage the ongoing relationship with the contractors through the 25-year MIM model. And I think it's imperative that you land your new strategy, which I think the current strategy ends at December, isn't it, this year, prior to the opening of that building, because it has got to be an integral part of what you've just described to Isabel, which is Velindre's got to be at the centre of how we deliver cancer care in Wales. So you just describe to me how that's going to work over the next 12 months.
Yeah, if I pick up the first point, Nick, and then Lauren will describe how we're going to manage the contract. Yeah, so clear. It's been a long road, isn't it, Nick? And we spend lots of meetings together. But as you say, I think we're in good shape. If I just quickly describe the governance arrangement we've got in place, and then I'll come to the management transition. So, as you're well aware, we absolutely recognise the opportunity and the responsibility this new facility brings with it. So we don't take that lightly. And we've got strong arrangements in place. So within the trust, we've got the NVCC project board, which also has seats around that table for Welsh Government colleagues, shared services, and health boards. So we're making sure that's collective endeavour. We've got the NVCC scrutiny committee, a committee the board set up specifically and only to focus on this project and the related dependencies. And thirdly, we've got the trust board. Externally, I and colleagues attend the health strategy board, which Nick and Andrew Jeffries co-chair. And then we've also got liaison committees, ourselves and Project Co, and we have 3 seats on the table. They have 3 seats around the table, and essentially that's to manage any potential conflict or dispute resolution. So you go there before anything escalates. So I think we're very strong on governance, and again, thanks to Nick and colleagues for helping us work through that. As you say, Nick, the construction phase, in a funny way, our requirements are relatively minimised. We've got to deliver on the trust obligation. So, for example, bringing energy to the site, section 278. We've delivered all of those on time to budget, okay? So we're good there. So the risk is different then, isn't it? So the risk is in two phases. We've got an operational readiness board, which I chair, where we've got two bits to it. So we've got the clinical commissioning of the actual hospital, and particularly around equipment. You know, there's in the project agreement, there's a very clear contracted for phasing of how we implement the equipment into the new building. We've got preferential access coming up in September for the Linux phasing. So that's a really, really important part. And that's where the commercial risk sits, because there are companies either side. If we delay the builder or they delay us. So that's the first piece. And then the second piece, Nick, talks to you about actually then training staff, inducting them, making sure we go into the new facility with different ways of working, using digital, those sorts and so forth. So in terms of the second piece, we've got very, very detailed plans which you and colleagues see, Nick. And we've also brought in subject matter experts where we know that's not our capability. So, for example, we've got really good people in commissioning and and so forth. But the scale of it is quite significant. So we brought in a specialist equipment provider to manage and help us to work through that. So that's the first big risk. The second element then is the service transition. And I know she's not with us today, Anne is not well, our chief operating officer. Anne is working with service to make sure we've got all of those things in place. So we've got a very detailed plan from staff training, staff orientation, ways of working. We've had 250 people just in October, December up and new the building. So people are quite excited because it's just over the side. They can see something coming. So we've got a very detailed plan, which is then comes to the project board, which I chair, where we've got two different parts to it. First is construction, and then the second is operational readiness. So that's how we are taking us through that. And what I will be doing then as acting chief executive in the not too very distant future is get an external view. I want somebody to come in and kick the tires to just make sure that we are seeing the same picture as they are seeing. So I'm getting an external view, as we do with the PwC, Nick, where we're not being, so a bit too kind on ourselves. So I just want somebody external who's done this before to come in and tell us where we think we are against the plan. The last thing, and I'll pass across to Lauren then about
this. Before you do that, so I get that's good that you're getting external general governance. What's your take about where you are with that?
In terms of construction, I think we are.
I mean, the member services side of things.
In terms of delivering up I think the plan is a good plan. We've got all the people lined up, government provided us resources, we've got the people in place. So I think we're pretty confident. I mean, look, I was told in a previous life, nothing ever goes to plan, it's just how you react. So we've also got to be agile and recognise that things won't go as planned. And making sure we've taken, it's almost that pre-mortem, isn't it? You know, what could go wrong? And let's make sure we get ahead of that. And that's again where I think you're.
But I think that the key point, Carl, is post-opening and post-deployment,
yes,
all of that resource and support goes away.
Yes.
And you're left with, how are you going to manage? Not clearly you've got service management responsibility, but managing what is an enormous financial contract for 25 years to make best use of that building with minimal support. I think it's going to be is key from a board's assurance and board governance.
I'll pass to Lauren this.
Sorry,
Yes,
before we move on, I just want
yes, I was going to say.
before we move on, I just want to be clear. I want to allow enough time for us to discussion on strengthening the organisation as well. So if colleagues' replies could be brief, so we can allow time for that as well. That'd be great.
Yes, of course. I think we are on the New Velindre Cancer Centre committee. We realise that we haven't got it quite right in terms of really melding together what is the service, the change programme with the development of the building itself. And we're in the process of strengthening that. Because I think we are in a different phase now, and if you've been, embedded in something, it's quite hard to step out of it. I mean, in terms of the risk, there's the risk to the staff our own staff who have been on the books, have been working on this. So we realise we have to think about, that from a cost and a human resources perspective, and also, as you say, the management that enormous contract, and Lauren can just briefly come in on that last bit.
Thank you. So, and apologies, Cabinet Secretary, I didn't introduce myself when we spoke earlier. So my name is Lauren Fear. I'm the Director of Place, Portfolio and Partnership for the Trust. So just very briefly, in the design of the operating model post-construction has been informed by the Welsh Government MIM policy, and is based on the delivery of the long-term value of the contract through robust contract management and ensuring the benefit realisation across the 25 years concession period. So as we've touched on, from March 27, Project Co will be responsible for providing the hard facilities, and then the Trust is providing the soft facilities management into the hospital. So we are responsible for monitoring compliance by Project Co with the requirements as set out in the project agreement, and then the payment mechanism as part of the project agreement enables us to deduct from the annual service payment any matters that do not meet the required standards, and that's what we'll be monitoring and reporting through the Trust governance on a regular basis. So the structure is, which will be part of my team, includes those two core elements. So the contract management, which will have the professional financial oversight via our Director of Finance, and then the operational oversight and compliance as part of estates and facilities management. And as Carl said, this work is forming part of that overall readiness programme and governance alongside the clinical commissioning and the equipment and the workforce readiness.
Thank you very much. We're going to move on to the last of the 4 items on the agenda, which is focus on how you're strengthening how you run the organisation. So we'd like to lead on that, please.
I would on that, and you've heard today how dynamic an environment we're working in. So obviously cohesive, skilled and responsive leadership is incredibly important. And we've got to support our people and help them to own the change that's happening. We need strong governance and excellent financial control. So over the coming weeks, we'll be refreshing the structure of our board and its committees, giving more support and assurance in key areas. We proposed new committees, one focusing on people, culture and engagement, another on finance, performance and planning, and that will open up space in the quality and safety committee to also focus on experience and deepen that focus on the things that you've heard about in terms of modernising the services and the way that we deliver those services and the quality. So we've been discussing those proposals together as a team since September, and they'll be coming to our Trust Board at the end of the month with the objective of getting them in place by the beginning of the next financial year. Following the publication of your review of governance accountability to the Shared Services Partnership, we're already talking to the team at Shared Services and also the members of the partnership, that is the health boards and trusts, and with yourselves about how we're going to move at pace to strengthen those governance arrangements, which are in essence good, but it was 10 years ago when they were set up, and so they do really need updating. We've got external evidence to show the Trust is a good place to work. Our staff engagement score is 76.5%, and we've got improving recruitment and retention rates and positive reports from regulators and auditors. However, we know we have to change. If we're going to offer patients the latest treatments, help more people, modernise the blood and transplant service and show that systems leadership that we've been talking about today, change can be really difficult and painful. And we've been in receipt of a number of anonymous complaints, which the board has taken really very seriously. We've done a number of things. So first of all, we opened up additional channels and ways for people to report concerns internally but outside the line management structure, and we also invited in NHS Resolution at Work to make themselves available confidentially to talk to the staff group that were most affected by the change. They've given us a report on what they found, and also some recommendations as to how we can get better. Now we're in the process of talking about that as a board, and we'll be talking to the involved staff first to feed back to them. You know, this is what NHS resolution at work told us, but no surprises. It tells us that we could have been better at managing that change, and you know we've got to get that right from now on. So we've got to really signal as a board and exemplify the behaviours and values we expect to see and that all of us deserve. And I think we have been doing that and will do that. I'm absolutely committed to that. So there is a lot of leadership stability. I think you can see that today. We've got lots of people at exec, non-exec, clinical leadership level throughout the organisation who've been here a long time and who are absolutely committed to this organisation and have helped keep us steady. And I'm incredibly grateful to them. And I am really grateful to Carl and the team who've stepped in as we had to, you know, face some difficult issues with our chief executive and that he departed the organisation and we had to coalesce very quickly. What we are going to do is complete the recruitment of the board substantively. So we've got a really strong and cohesive team going forward. And we've agreed as a team what we want to work on in terms of strengthening our own leadership culture and capability. There are changes going on in the blood service as well and a modernisation programme there. And we've just completed a restructure in the cancer services leadership team. So we've got medical, nursing and management leadership working as a triumvirate, which we have not had before. And I think that is going to be instrumental in changing that service. So exciting, but difficult. And in terms of our finances, we're forecasting break even this year, as we promised in the IMTP, but there's no doubt that the financial outlook it's really challenging, you know, and we are as well in the way that we're changing our governance, we're going to increase the focus on finance and performance so that we're also looking at benefits realisation from what we've invested and efficiency. And that will be folded in also into the IMTP, which we hope will give you an approvable plan.
Okay, Jeff, so look, obviously there have been specific concerns raised in relation to governance. Some of that been in the public domain, as we know, or know. There's been the review of the governance arrangements with shared services, which you referred to. I want to understand two things off the back of those developments. So firstly, the steps which the board is taking to improve governance, to what extent do they go beyond what's in the review, which the Simon Dean review best state, and then secondly, it's an approach, I suppose. It is the board's view that there are a range of actions which need to be taken and which will be taken, which will improve governance, or is the board's view actually there needs to be a different approach to this? Because those are slightly different perspectives, aren't they? So what's your...
So for me, I think, and for us, there are two things. The one is the review, the Simon Dean review, and what we need to do around shared services and hosting arrangements. And I think there are two things there. One is there's quite a lot of detail to work through. And I think it's really important that we do that in partnership with the organisations who belong to the Shared Services Partnership and with the Welsh Government. And then the second thing is the culture and the way that we get on with each other and the way we behave, which has got to be grown up and focused on what the NHS needs. And I'm really grateful for the chair, Tracy Myhill of the Shared Services Partnership Committee. I'm going to meet her. She said, take your time to do the capability review first. And then as soon as that's done, she and I are going to sit. Carl has already sat down with the managing director of shared services, and we have agreed that we're going to get round a table and go, okay, let's reset and let's really get to grips with doing what's right here. I think there's a lot of detail to work through, but we have to do it in the right way and with the right spirit. So that's one thing. The second thing is, I think we're in a different phase in terms of our own development. So our own governance as a trust is evolving to meet that. We've had a mega committee that's been chaired by Vicky brilliantly, but it's a beast. So we are going to break that up. So we've got people, culture and engagement, because I think we need to really focus on our communications and our engagement, both because of our role in the system and because of our, our obligation and our partnership with our staff, and just more generally the confidence of people in Wales and the pride of people in Wales in what we do. We're going to have a finance committee, a dedicated finance committee that's also going to look at productivity and bringing out the benefits from the things that we've already done. And that leaves quality and safety to also focus on partnerships and some of the service changes we've been talking about today. And the other thing that we're going to do is review the way that we run our charity. It's a fabulous charity, and it deserves more attention from us in terms of supporting its direction and its governance and its strategy. So there are two things we have to do simultaneously, and there's a bridge between those things, because if we're going to be efficient and effective, there may well be things that we can do, not shared services Velindre, but shared services and Velindre, which will enable that committee, the Shared Services Partnership Committee, to focus on the actual service, not on these background governance issues, which absolutely need to be covered, but they're not part of the business of delivering brilliant services to NHS Wales, which are properly transparent and accountable. So there's lots of opportunity.
Can I just thank you? Can I just pick up on one issue which might have a read across in that context? So you've talked about the elements of stability, which is great. There have obviously also be elements of change, and they come at the same time. So understandably, that causes a level of instability conceivably. I wanted just to get a sense from you. You touched on culture. Yeah. What steps from making sure that the organisation has the supportive and compassionate culture that we all want? What from what you've described will you be doing in that space?
Okay, so colleagues at the other side of the table set me a challenge when I came in. Can you assess culture? And actually it was brilliant, because what it enabled me to do was to ask for the metrics we had, to sit on every committee and see what they discussed, but also to spend time in the service. And, so every week I'm either at the blood service or the donor awards or the cancer service, and I just chat and I just watch. And other people around the table do the same thing. And we also had some very honest discussions around the board table. What do we think? Where do we think we're at? What do we need to look at? So I don't want to do down what I've heard in terms of actually some amazing elements of culture in the organisation. And I do want to pay tribute to the staff, because I just think they're amazing. And we're extremely lucky to have them. However, it's really clear that some people are quite upset by the changes that have happened in the cancer services. And that's why we asked NHS Resolution of Work. And actually, we asked the RCO to come in as well and speak confidentially to people. So we had to change. And,
is that your main driver for that culture change then?
It's wrong to change. It's not just that. It's like something you have to do. I just don't think you have a culture in a set aspect. It just isn't. It's really dynamic. And it has to be responsive. So it's a good thing to do anyway. And everybody needs to take accountability. It's one of the values of the trust at all levels, and that's a really strong message. We can't shy away from this change. We can't say, okay, we won't do what we've got to do then. At the same time, we've got to do what we need to do in as compassionate a way as possible. So that's really, really important. And I think we need smarter evidence base of what our culture is like. And I think Sarah and I have had good discussions about this. So we've got some good top level metrics, but we absolutely need more. and Lindsay has stepped up as a new Speaking Up Safely champion. And honestly, you know, we've had to take some very fundamental action in terms of changing our chief executive, and that's, you know, we will do the right thing, but we have to persuade people that we'll do the right thing.
So you touched on some stuff feeling, I think you said the word upset, I think you used the changes. So just wanted to get and this particular responsibility which you just alluded to. I guess the fun thing from being in this space is then recognising that you obviously have, and you described a process which you've embarked upon, which sounds positive. If I'm a member of staff who still is a little uncertain, what specific actions will come out of the work that you're doing, the process that you've put in place, which will enable me as a member of staff to feel speak up safely? And I'm not suggesting there's a huge or simple challenge here, but there will be examples. Clearly, you've identified that there have been examples. So how will that? What were the specifics that will make me feel better about that?
I'm happy to take that, Cabinet Secretary. I'm Sarah Jenkins, the Interim Director of People and DE. Good afternoon, everybody. So we've taken a number of quick steps, but we recognise in terms of speaking up safely and building that it's a relationship, and so therefore we've got to be recognizant of that and how long that will take to build trust again with some of our staff. So giving them plenty of different channels, we acted quickly to introduce the Working Confidence platform. We've increased the visibility of the executive team and leadership around the organisation, just to give the opportunity to have a chat with us, see that we're visible, see that we're accessible as well. As the chair has indicated, Lindsay has agreed to become the independent member for Speaking Up Safely, and that will allow us an opportunity. We have a campaign to promote. Actually, we've already had feedback from our staff that is something that's really welcomed, because that allows direct access to the board, and we will ensure that we make all staff aware of that, because we're a slightly smaller organisation to some of our colleagues. It allows that much more personal approach, and I think actually that's been really key in terms of starting to rebuild the trust, and we're already starting to see an impact of the new leadership on the ground positively as well, and the chatter on the corridors in terms of how that feels. As my chair acknowledged, we've introduced new data insights in terms of the way that we're looking at workforce metrics, heat maps, triangulation of that data, qualitative and quantitative, instead of just the 4 simple metrics that you would expect us to report on. That's given us a much different conversation at the committee as well. We've also introduced service-led discussions around what those metrics mean. And again, that allows us to really understand what really are the risks that we're seeing on the ground. Because when it comes to speaking up safely, there are a lot of initiatives organisations can do, but those that really make the impact are the ones that actually meet the need of this particular organisation. And I want to echo the chair's sentiment there. I've been here 2.5 months. Velindre really is special, and you feel that when you walk around. And therefore that personal approach, I think, is really critical for all of us here in terms of building that trust. That gives a flavour. All of that goes through our governance system. We have a culture and inclusion report that is reported through our board and committee. We've been fast to act to adapt that, and we will continue to keep a strong eye on that in terms of giving assurance.
Okay, thank you very much. Sarah, we've reached the end of the 4 topics we were hoping to discuss in the meeting. There is a short few minutes. If there are anything that you want to draw to our attention or highlight that we haven't had a chance to cover on the agenda so far, there's a few minutes for you to do that if you'd like to.
Thank you very much, and thank you for the opportunity, because actually the thinking time that we've spent preparing for this has been really helpful in, you know, grounding us in assessing where we are now. I'm going to take it back with us for our planning. We are strengthening the board, and since I joined in September, I think I've said I've spent, you know, at least some time every week in the service, and I just wanted to give you a flavour really before we go. I've witnessed just passion, professionalism, commitment. The donors that we have, the donor awards, are just amazing. People love Velindre because the care they get is personal and heartfelt as well as expert. So I was with the radiology team last week, and they know the names of every patient, and often they track patients for many years. And they've got a little file called Miracles, and they were showing me the different slides that they've taken of people coming in with multiple metastases and living to see their children grow up, and 15 years later being free of those metastases. I mean, it's just brilliant. And the radiographers just stopped what they were doing because one of the patients on the machine was incredibly distressed. So they just stopped, they took her aside, they talked to her, they held her hand, and she came back and she was much better. So the essence of that, we've just got to just keep that, absolutely. And that's why so many people, volunteer and want to participate in the charity. And as I said before, we really need to support that charity. So we're determined, I think, I'm determined as a chair, that the values we've got are caring, respectful and accountable. So, they've got to live. And I want to thank the team here because they've really, coalesced. I really do feel they stand alongside each other and me. So thank you. And our ambition is to be an outstanding specialist centre in cancer and blood. There's a lot to do, and there's a lot more we can give, and a lot more that we can perhaps talk about in a systemic way about how we sustain that ambition and that drive.
Thank you very much. Thank you to everybody for the time today and the discussion that we've had. There are three things which I think leap out at me from the discussion that we've had. Firstly, is that focus on evolving ways of working to reflect both the challenge of increased demand, but also the opportunity which is coming from the new treatments and the technology. And secondly, obviously the successful delivery of the new centre and making sure that the BIM element of that into the future is as effective as the delivery of the project itself. And then thirdly, a continued focus and as rapid as possible in implementation of the changes that you're already planning in relation both to governance and evolving report share. So I think those are the three themes which have really stood out for me in the discussion today. But can I thank you all for your work? Thank you for the discussion today. Diolch yn fawr iawn i chi gyd.
Diolch.